uh, by Dr. Suganthi Iyer. I would like to welcome ma'am, who would be taking the session on medical legal aspects of digital documentation. It's my proud privilege to introduce ma'am, though she doesn't need any formal introduction as such. She's the medical legal consultant and hospital administrator at Hinduja Hospital. She's from State GS Medical College and KEM Hospital, Mumbai, and is a qualified hospital administrator, as well as she's done her law from the New Law College, Mumbai. And presently with Hinduja Hospital, she's the director, legal and medical, and she's also the visiting faculty in law at the University of Mumbai, TISS, that is Tata Institute of Social Sciences, and various other institutes. She's also an NABH assessor, faculty for NABH workshops, and member of the NABH Appeals Committee, and has participated in a large number of workshops on the legal aspects and contributed to publications and chapters in books pertaining to the legal aspects of healthcare. Her area of forte is legal, medical legal, and hospital administration. And she has been the convener of the medical legal cell of Indian Medical Association Mumbai branch for several years. Welcome you, ma'am, and over to you for the next session.
Okay. Thank you so much, Dr. Patil, Bombay Hospital, Dr. Kaho, through Dr. Subin Shetty, and to say that the first three speakers have really made my job easy about the medical legal aspect, and Dr. Martha, by a good introduction to digitalization, has also made my job very easy. I would now go into those aspects which have not been trodden by the other speakers. So therefore, what I would like to present is the way the court looks at the documentation, the legal aspects of documentation, which we have been speaking for over the last so many speakers. What is the impression of the court, since that is the most important thing we are concerned with. So first aspect, as Dr. Sanjit Singh had said, that there are many aspects about the medical record, consent, pre-op, post-op, intra-op, discharge card, and so on. I'll deal with several aspects, spending few minutes for each. In consent, the standing judgment is the Supreme Court judgment Samira Kohli versus Manchanda, which was there in 2008 March, and this has made the consent as a specific document which we have to be very careful while taking. This judgment clearly says that the consent has to be taken from the person upon whom the procedure or the surgery is going to be performed, and none other, provided the person is more than 18 years of age, is conscious, is mentally sound, and is in a current stage to enter into contract. And this judgment clearly says that it has to be there for the specific procedure, and no other procedure can be done, and only in an emergency condition, then only somebody else can be allowed to give consent, as well as in an emergency situation where it would lead to a shortage of the life. Only in such conditions can we traverse and go beyond what the consent is taken in order to save the life of the patient. Also, if when we operate upon the patient, if there is some other condition which we discover which also needs surgery, just because we have opened up, we cannot do the surgery, but we have to close up, again explain to the patient, and then again take another consent, and then proceed for another surgery, barring except life-threatening condition. And after this judgment, we have got litigations have shot up. Almost 40% of litigation in consumer court, high court, city civil court, and Supreme Court, etc., dealing with medical negligence is that purely on consent. Example, Ram Gopal Varshni versus Laser Sight India, wherein an 85-year-old gentleman got operated for cataract and recovered the vision completely. However, his advocate discovered that the signature was that of his grandson of 25 years, wherein the ophthalmologist felt that this person is 85-year-old, why not take that of the 25-year-old grandson who's much younger? And despite the patient has recovered the vision fully, the advocate filed a suit, and for that the surgery was done without the consent, and the patient won almost 5 lakhs of rupees, though he has paid just 50,000 for the cataract surgery, just because it was taken from his grandson and not him. So this shows that you have to take the consent only from the person upon whom the procedure is being done. In Kailash Moradia versus Punjabi Nursing Home, the signature of the patient was missing and therefore they had to pay compensation. In Thomas versus Eliza, this stresses upon the need for informed refusal, wherein if a person is refusing a particular procedure, whatever so it may be, whether it is IV procedure or an admission or an administration of a medication or doing of a diagnostics or anything else or surgery, you have to take a written consent in the proper consent form, wherein in this case, the patient came with a acute appendicitis to the emergency room and the surgeon said an emergency surgery is required and the relatives refused, wherein later on, the surgeon then started the conservative treatment, but after 12 hours, when there was a perforation and septic peritonitis, and the surgeon went on to tell the relatives that it is life-threatening and without surgery, the patient may lose his life. Then the relatives consented to surgery. Ultimately, since there was a perforation and septic peritonitis, the patient ultimately, despite surgery, lost his life after 5 days of surgery. In the court of law, when the doctor was interrogated as to why he delayed 12 hours for the surgery, and he replied it was the relative who said he wanted conservative treatment. But the judge asked him, did you take it in writing from the patient? Where is the evidence that you have explained to the patient that surgery is mandated, but the relative has refused? There was no document, no evidence that the doctor could show that he had explained that the surgery is mandatory and imminent to the relative, but that the relative had refused. So therefore, from this, it is deduced that even if the patient refuses a particular procedure, anything that so may be, you have to take it in writing, and this has to be in a proper consent form and not on the progress note, as we will see in the later judgments. In Roja versus Whitaker, it is very clear that even if the adverse effects or the side effects is only 1% for a particular surgery, even then you have to take it in writing, which is known as the material risk. For example, a surgery on the hip joint is different from that of a knee joint, different from that on the spine, wherein though there are generalized side effects like infection, hemorrhage, loss of life, etc., but a specific side effect, for example, a particular nerve or a particular vessel or a particular deficit that would happen should be explained. In this case, a 38-year-old lady who was undergoing a surgery for a squint, and she was only one eye, and she was undergoing a surgery for the better eye. There is something known as sympathetic ophthalmoplegia, wherein the vision with which a person is seeing can go blind just because the person is operating on the squinted eye just for cosmetic purpose. So in this case, the lady underwent a squint surgery on the squinted eye just for cosmetic purpose, but she lost the vision in the single eye with which she was seeing. The doctor had taken a generalized consent, though there was a 1% chance of loss of vision in the eye through which she was seeing. He had not taken in writing, and this is called the material risk, wherein even a 1% side effect would be 100% for the patient, and because of this, the doctor had to pay the compensation. In Rohandeep Jaswal versus Kokilaben Dhirubhai, which is a very, very recent judgment which was released just 1 month back. This shows that any consent you take should be on a proper consent form. In this case, the side effects of the specific aspect of the spine surgery at a particular level was taken by the doctor in the progress note and not in the proper consent form, wherein the National Commission decided in this case, the petition asked for 56 crores. Compensation of reasonable amount was granted. Purely besides other defects, other reasons, also one of the main components was consent, which was taken in the progress note for a specific reason and not in the proper formatted consent form, where the judgment said that every consent should be taken in a specific formatted consent form and not written on the progress note, which many doctors tend to do. And now for the shortage of time, I will progress to further other aspects of documentation. Discharge card is very, very important to be released. Jaipur Janana and Surgical Hospital and versus Kaushalya. Here the patient was admitted for a tubectomy and discharged on the same day from a daycare. And after a few days, she did the follow-up. After several weeks, she went to another nursing home with complications. there they had asked what is the surgery which was done and what was done. This patient had not received a discharge card because it was a day case surgery. And therefore, because of the complications, later on, she had a lot of injury and she suffered a lot, for which she sued for compensation. And the court said that the first hospital where she did the day case surgery had given only a prescription and not a discharge card. And therefore, what was done, what antibiotics were given, what was the procedure was not narrated by the particular nursing home when they reached the other major hospital for complications, leading to a delay in treatment. And therefore, from this, it is deduced that for every procedure, however minor, you are bound to give a discharge card, more so for day case surgery. In Lakshmi versus Gohil, it is said that the patient had a fracture forearm bones and the plastering, etc. was done. The patient was told to follow up after 3 days verbally for a check X-ray, and after 1 month just to see the alignment of the bones. That was given in writing in the discharge card. The 3 days post-operative follow-up was told verbally. The patient chose to follow what was in the written instruction and chose to come after 1 month, thinking that what was told verbally was just casual. We need not just pay attention to it. And he came after 1 month. And that time there was malunion. The doctor had to again go ahead for another surgery for correction. And for this, the patient sued the court, sued the hospital and the doctor. And in the court of law, the doctor said that though we had told the patient to come after 1 month in discharge card, we had, however, told verbally to the patient to come after a few days for a check X-ray. The court clearly passed the instruction that whatever you have to say to convey to the patient should be in writing and not verbal. And the doctor and the hospital had to pay compensation. Wherein in the other judgment, Narayana versus Apollo Hospital, the doctor had given in writing to come for bone marrow transplant after 15 days. The patient came after 6 months and later on succumbed. And for this, the hospital won the case because of the instructions given in writing. In one of the important aspect is preoperative notes and preoperative anesthetic assessment. In Pushpa Bhandakar versus Varun Hospital, wherein a young person of about 30 years was taken for a shoulder dislocation surgery, and the anesthetics thought it is okay if we do not do a preoperative assessment, but on the OT table, the person arrested and the patient had to be intubated. It was a very difficult intubation. The patient was obese with a short neck, and because of that, the patient had later on arrested and the patient expired. Later on, when the relatives sued the hospital and the doctors, the hospital lost the case because the anesthetic had not done a pre-anesthetic assessment. It was not visible. And this shows the importance of pre-anesthetic assessment immediately before the surgery. Even though you think the patient looks fit, is young, is still a mandatory documentation. As far as intraoperative note is concerned, this is also very, very important. The OT notes are of mandatory significance, goes a long way to show what was happening in the operating room. In this particular case, the patient had lower limb issue and was taken in the OT, and the surgeon had written in the OT notes, it is removal of the implant from the fibula. The anesthesiologist had written it is an ankle arthrodesis. So in the intra-op notes, OT notes, the anesthesiologist and the surgeon had written 2 different diagnoses. Also on the OT table, there was a cardiac arrest which was resuscitated. The patient was then taken to the ICU and died a couple of weeks later. Later on, the relatives made a litigation against the hospital saying there was alleged negligence. In the reply that is filed by the doctors, by the anesthesiologist and the surgeon, they clearly mentioned about the cardiac arrest, but in the OT notes, there was no mention of the cardiac arrest. Besides that, there was discrepancy in the anesthesiologist's diagnosis and the surgeon's diagnosis. There was discrepancy in the exact time by both the doctors, and because of non-mention of this event, the court concluded there was discrepancy in the documentation of medical records, and therefore, and also it was not properly recorded, more so of the cardiorespiratory arrest. And because of all this insufficient documentation, the hospital and the doctors lost the case. Post-operative documentation. Yes. How many minutes left?
Ma'am, we are already overshot the time. If we can.
So I think I will stop, because I mean, we can just go on and on. Post-operative notes, etc., being important. Monitoring notes during anesthesia being important. Assessment notes in ER being important. Prescription, capital, etc. reassessment notes, implant, the importance, transfer summary, including llama being important. I will go by you, Devasri, because I know the other speakers are there. Referral, to have several judgments to speak on, and about other things, and about e-record, which validity we have already spoken, scan signature versus digital signature, so on and so forth. I stop here because we have other speakers as well. No issues. Thank you so much, Devasri. I would feel free to take any questions from your side, and that's it. No issues.
Yeah. Thank you so much, ma'am.
Yes,
Thanks a lot for such an enlightening session with so
Yes.
many medico-legal case studies.
Yes. There are
Yeah,
plenty every
yeah.
month. And more so, every month there is at least minimum a couple of them on consent. You see,
Wow.
and if you
Yeah.
go to narrate all the judgments which I have, in fact, this what I list was a very concise list. It would take a brief workshop on its own. But the reason why I like to show judgment is that is the one which creates the impact in healthcare professionals, that this can happen if I don't do this, if I don't do this, if I don't do this, implication of every aspect of documentation of medical record. That's all I wish to say in brief. Thank you so much.
Thank you so much,
Yes.
ma'am. There are many questions. One or two I'll take up now.
Sure.
Yeah. So one is there, is DNR or
Yes.
DNI forms, if it is properly filled, is it legal? And
DNR, I think the DNR, I think it was already answered by Sanjeev Singh. And see, DNR is not legal. You cannot document DNR. Let me tell you very clearly, DNR is not to be documented. If you document, do not resuscitate. It will be illegal. For in the Code of Medical Ethics, Chapter 2, it is clearly mentioned that you have to do your best to save the life of the patient in an emergency. Therefore, for consent, for an emergency is not required. So if for a resuscitation, we need not take consent. Okay. So, but you have to resuscitate because the paramount duty of a doctor is to save the life of the patient. So DNR is illegal. Documentation of DNR is illegal. Taking consent for DNR is totally illegal, but it happens in every hospital, in every floor, with every consultant all the time. So, but one has to be careful. If anything, one goes into a litigation, that particular document, is dangerous. So they will say that my patient lost their life because they did not take the trouble to resuscitate. So now we have other ways not to resuscitate in a quiet fashion, by tripping over a tube or tripping over a button, etc. The thing accidentally fell off. You see the switch, etc. So there are many other ways we can have it with a good understanding with the relatives, but one should not document it and not prepare a consent form for it. However, you can have a consent form for not having escalation of treatment, that you do not want treatment, for refusal of treatment. As I said, you can have a standardized consent form for refusal of treatment. And when I say refusal of treatment, that refusal for further escalation of treatment, further escalation in the form of shifting to ICU, for administering antibiotics, for doing dialysis, for IV fluids, and so on and so forth. So indirectly, this shows that yes, I will take only other symptomatic treatment, no dialysis, no antibiotics, no inotropes, etc. So take a refusal for administration of all these drugs, and that is enough. And slowly, within a couple of days, the story is over.
Okay,
That's
thank you
all.
so much, ma'am. Thank you
Yes.
so much. There are many
Thank you.
questions. Can you please answer that?
Yes.
Offline? Yeah, ma'am.
Blood
Maybe just a
transfusion
time.
and all these things. Yeah, blood transfusion, actually you have to take for every transfusion as per the blood transfusion rule. NABH says once in 6 months, but NABH also says that before every transfusion, take a separate signature noting the assent. This is both for transfusion as well as dialysis. So to decrease the volume, you keep the same consent, but you can make a name, date, and the signature, and that you have informed, and the signature. You see, that should be okay. Anything else?
Yeah. Yeah,
Ma'am, just to intervene,
yes.
Dr. Disha, just to intervene, how is digital documentation? How are the medico-legal aspects connected to the digital aspect of documentation, ma'am?
Yeah,
consent. Yeah, if you can throw a little light on that.
Yes, definitely. See, whether it is digital or whether it is hard, the medico-legal aspects are the same. Now, basically what we are trying to say, digital is permitted in a court of law because of the amended Indian Evidence Act 1872 in 2002 and the amended and also the Information Technology Act. So the digital documents are this thing. Now, as far as the legal aspects are concerned about, see, what happens is that if you leak out your password, you are allowed to tamper, it is with your own thing. You see, that is all. Otherwise, so far, there are no major judgments to my knowledge. Of course, it is not that I will be aware of each and every judgment that is there. So they could have been, but it has not come to my notice specific on digital. But of course, Dr. Martha was speaking about signature. Now, today, if the relative also is having the digital signature and he can put it on the consent form, that itself can also be, you see, a good way to store a consent form. So far, I'm not really aware of any judgment basically being on the digital documents. To my knowledge, everything is still going, at least in Indian courts, on these type of this thing, except probably where there could be a tampering which unauthorized or something. Anyway, of course, if anybody else has knowledge, no issues.
Thank you so much, ma'am,
Yes.
for the lovely session. As usual, we can go